just another minute or so to gather in, but I'm Keith Van Haren. I'm a child neurologist at Stanford University. I have been involved in ALD Connect since it started, and ALD Connect has been a wonderful organization to work with. I'm thankful to be invited here today. I'm going to present on the results of our recently completed pilot study of vitamin D supplementation in ALD boys. I'll outline how we got interested in vitamin D and tell you a little bit about the trial design and the results and what some of our next steps are. I do some consulting for companies working in and around the ALD space. That's my primary disclosure. None of them directly relate to this study. We don't have any commercial interests in vitamin D as of now. And this is my, or the team who contributed to this trial. I want to give a big shout out to my lab team here on the left, and then to big shout out to the Kennedy Krieger team, who is our second site. So Ali Fatimi led the study at Kennedy Krieger. Peter Barker was gracious enough to lead the MRI work, and Jerry Raymond helped initiate it. So all three of these people worked with no pay for this project. I'm incredibly grateful to their work. And then the other collaborators here on the right have all contributed to various aspects of the science here. I'll detail some of their work as we go on. Okay, so this is our ALD team at Stanford. I'm really proud of the team we've assembled here and what we're doing. We've got a very large ALD clinic population and a really terrific team who see boys as well as adult men and women with ALD. So if you're in California or on the West Coast, please do feel free to seek us out. All right, so let's talk about cerebral ALD. This is the primary interest of my lab's research. And as many of you know, there are sort of two bimodal peaks of cerebral ALD risk over the course of life. The big peak most of us are focused on is in childhood, but there is a peak in adulthood as well. And but the interesting thing is about a third of males never develop cerebral ALD. And so this is one of our areas of interest, is kind of areas of resilience and vulnerability of metabolism and immunity in ALD boys. And these are what the lesions look like. These white spots in the brain are the ALD lesions at a large stage. So all boys begin life with no lesions, and then a subset of boys will develop lesions here, as exemplified this bright spot with this contrast enhancement. And then if the lesions are not caught early or they're not treated, they will generally continue to grow. And so we do have an excellent treatment paradigm for early stage lesions. That's bone marrow transplant and emerging gene therapies. This is a really superb efficacy for these therapies at an early stage. Advanced stage is much more complicated. Really excited to see Troy Lund's work on this in the last talk. I think it's the beginning of some additional promising work in that area. But our real goal might be to prevent the lesions from forming altogether. To take a step back, what do these lesions entail? I want to tell you, I'm going to foreshadow some of the work we're looking at in the trial by telling you about some of the pieces of ALD disease. So, brain blood flow in the brain is, of course, crucial to its function. And many of you will be familiar with the idea of a stroke being a brain injury due to decreased blood flow, as shown by this dark blue area here and here. And this is work by Patty Mussolino, who's been a real pioneer in this space. She's identified that these brain lesions also have, in ALD, have decreased perfusion that do resemble stroke in many ways. So decreased perfusion and blood vascular irregularities do seem to precede disease. And then work from Florian Eichler and others has really highlighted the role of macrophages and microglia in the lesion progression. These are believed to be central to the disease process in cerebral disease. We also know this is work from Ali Fatimi's lab, showing sort of a deficit in antioxidant capacity in those same monocytes and microglia. So we're going to come back to this, but let's. Our study will address each of these points in some form or fashion. Let me come back to this in a moment. So, all right. So similarities between ALD and MS. Let's talk about how we got interested in vitamin D to begin with. So ALD and MS are both inflammatory demyelinating diseases that affect the brain. The histology in these two disorders, in ALD and MS brain lesions, are actually very similar, more similar in some ways than MS is more similar to ALD than it is to some of the other inflammatory demyelinating disorders like NMO and ADEM. And so our lab has been trying to harness some of these similarities to develop insights in various ways. And one of the paths we've taken is to look at risk factors for multiple sclerosis. And the most kind of well-known and well-studied modifiable risk factor for multiple sclerosis is vitamin D status. And this was first identified when people noted a latitude gradient, meaning that people at different latitudes around the world had different risks of developing MS, and those at the higher latitudes had higher risks of MS. And many began to think that this might have to do with lower levels of sunlight at more northern latitudes. And so sunlight is one of the basically the key a key step for making our own vitamin D. It's a process that occurs at the level of the skin. Sunlight exposure to the skin helps produce vitamin D for our bodies. We can also consume it through the diet. That's how much of it is consumed or produced naturally, is through our skin in the sun. And lo and behold, after lots of study in the field of MS, it does appear, this has been replicated numerous times, an effect of vitamin D such that higher levels produce lower risk of brain lesion development, and also lower risk of early life exposures can reduce the risk of developing MS later in life. So you can reduce your risk of developing MS altogether. And so this is a pretty simple idea to apply to ALD, where we have an inflammatory demyelinated disease that we'd also like to prevent. And so we had long ago, we've shown before some of the data on looking at early life vitamin D exposures and later life development of inflammatory brain diseases, and this is through plasma levels. Josh Bonkowski is going to show some cool new data on latitude levels and cerebral risk, much like we have seen in multiple sclerosis. But our interest here after seeing this was, well, okay, we've got a pretty safe and available therapy. Can we apply this to ALD, and why in the world would it work in ALD? And so generally speaking, vitamin D is believed to it is proven to provide some important immunoregulatory properties. So where the immune system is basically can become aggressive or benevolent is sort of through some various immune checkpoints. And vitamin D3 helps regulate some of those immune checkpoints. And it helps regulate it at several levels, in dendritic cells, in T cells, in monocytes, and so on. So this is an obvious point. This is what is believed to be the mechanism in MS, as far as anyone knows. And this has been studied by our lab and by others. And oxidative stress is also, I mentioned, a deficit in ALD. So our lab hypothesized, this was a long time ago now, that glutathione might be regulated by vitamin D. And there was, at the time we hypothesized, there was just the beginnings of some early signals in this area. There's now a really robust data set including from clinical trials. So many randomized clinical trials, actually, I think more than 10 have shown a change in glutathione levels in the blood with vitamin D exposure. So we're arriving at this with our trial results here a little bit later than some others have, but we were early to the ideas, and I think these are some interesting avenues for the field in general for ALD. This is some of our data suggesting that vitamin D is increasing glutathione levels in the monocytes in mice with who were induced with demyelination, and then I hope to get to this a little bit later. We won't have time to talk about this in this talk, but vitamin D's role in lipid metabolism and regulation, we think is potentially relevant here to ALD as well. So we've wrapped this up with some collaborators to look at glutathione levels in the blood at both the whole blood level and then the flow cytometry level to look at immune cell subsets. We're looking at glutathione levels in the brain, and we're looking at blood flow parameters in the brain. So we've put this into trial format. I will say the most important and key part of the trial was really to look at vitamin D dosing and safety. So the scientific parameters were actually secondary outcomes. But we set out here several years ago to enroll 20 boys for a 12-month exposure, where we started them on a particular dose of vitamin D, what we thought was a medium to high dose, and then increased them if their levels were not achieving a certain level. And at each point, we were incorporating the markers I was describing a moment ago. And I'll show you our, we did this at 2 sites, Kennedy Krieger and Stanford. We began enrollment in October 2016 and completed in completed enrollment June of 2020, or June of 2019, and then completed our follow-up in June of 2020. So we're looking at pharmacokinetics and safety, some antioxidant levels, and then we weren't powered to look at brain lesions, but we did not see any, I can tell you that now. So inclusions were boys with ALD between 1.5 and 25 years. No evidence of brain lesions at the time of entry, and their vitamin D levels had to be below 60, and they had to have no abnormalities in vitamin D metabolism. This is just on our enrollment timeline, beginning back in 2016, and then got our completed our final study visit just actually a few months ago. So our initial dosing assignments here, where we started all boys initially at 2,000 a day, and then increased to 4,000 a day. What we realized about halfway through the trial was that even this low level was too high a dose for some of the smaller boys, and so we switched to a weight-based regimen. So we essentially had, in effect, 2 arms to our study. We had a first arm was a fixed dose regimen, and the second arm was a weight-based regimen. That did allow us some degree of comparison to see which of the regimens was going to work instead of comparing which of the doses was going to work. And I think that works fine. So for the first 2 years, we enrolled patients into this fixed dose, and then before our data safety monitoring board and I decided it was better to switch to a weight-based regimen. All patients made it to end of follow-up, and all patients were included in the analysis. Our median age for all comers was about 6 years of age, about 20 kilos. We did have a mix of ethnicities. Most patients enrolled, of our 21 patients, had adrenal insufficiency at the time of enrollment, and baseline vitamin D levels were 29. And then our subgroups were reasonably similar by comparison. Here were our kind of overall vitamin D results. These are our clinical trial coordinators who led much of the work here. This is Dahlia and Lindsay. So if you were in the trial, you spent a lot of time speaking to both of them. They did a wonderful job. Here's where our patients started in the study, and here's where they were by 3 months, and they generally held pretty steady. But if we break it up by group, we can see there was a slight difference in group. Our fixed dose group, as you might expect, had achieved higher levels because they were getting, in some cases, much higher weight-based doses compared to our weight-based regimen, which provided a more moderate dosing with it. I'll show you a better safety profile. Overall, this gray area here was our target range of vitamin D levels, and most patients went from outside the target range to inside the target range. In black here is our weight-based dosing. You can see that these were actually some of our heavier and larger patients. So these patients tended to be underdosed, which we would try and account for in future trials. On the other hand, our smaller patients who were on the fixed dose trial were overdosed, and their levels went higher than we intended. Though, as I'll show you, there were no significant clinical effects with those levels necessarily. But our primary interest here was looking at actually whether we achieved target levels. And I can tell you that at 12 months, about 2/3 of the patients had achieved and remained in the target range throughout the study. This was true of both arms, although I will say that, as I mentioned, the weight-based dosing was a little bit under target and the fixed dosing was a little over target. So probably finding a happy medium between the two will be our next step result for future trials. Here's a map out of our adverse events. So this is your elevated urine calcium creatinine in one patient. Here's a vitamin D level above threshold. We had, so these were several laboratory violations not associated with clinical symptoms, but these are the lab thresholds we had set. These were the thresholds that basically prompted us to switch to this altered regimen. And we did get a better safety profile from a lab threshold standpoint. These are the relative doses here. So for each child on each dose, this is not tell you the weight of each child, but just to give you a sense of what doses children were exposed to here. So we had, these were our predefined events. So plasma levels, calcium levels, there were no abnormalities in calcium levels, urine calcium levels, kidney stones, brain lesion development, etc. We had, as I mentioned, laboratory thresholds exceeded in the fixed dose group. We had one hospitalization for asthma attack, which we don't think was related to the trial. And we had one patient in the weight-based group develop adrenal insufficiency during the course of the study, and again, not clearly related to the trial. There was an issue, a surprising difference in just general adverse events that we didn't think were related to the trial, although the readout here is kind of interesting. I'm not sure, again, that it's related to the trial, but there were more events reported in our fixed dose group than in our weight-based group. These would not generally be considered to be vitamin D related. Here they are. Here's our dose per weight. This is just to say for every dose per kilogram of body weight, what vitamin D level did the boys achieve? And I think that the sweet spot here is somewhere in the 50 to 100 IU per kilogram range, where the patients didn't really go over level, and most of them were within range. There was an interesting aspect of this, though, in that it wasn't just the weight that predicted their dose, it was actually their age that predicted their dose response to. And this has never been reported before that I can find. This looks like we got a significant value here in an association. So I think this might be real. This is basically the dose response when we're adjusting for weight. If we just eliminate dose per weight and use age as a stratifier, this is how this plays out. So we plan to use this to generate a kind of a calculator to identify proper dosing levels in the future. So those were some of our primary outcomes. I'm going to run through our secondary outcomes here real briefly. Here's glutathione levels in the whole blood. You can see this is the antioxidant marker I mentioned before. You can see levels are going up. They don't achieve a statistical significance here by 12 months in the whole blood. We did in our flow cytometry analysis hit statistical significance in lymphocytes and non-classical monocytes. Our classical monocytes were not quite at a significant level here. And we did not have a significant correlation with vitamin D levels. So on a single arm study, it's hard to make a causal claim on this, but we think this is a promising result. And as I mentioned before, actually most of the clinical trials that have looked at vitamin D's association in randomized controlled trials have shown actually that vitamin D does increase glutathione in the blood. So we think that we're simply, this is in keeping with the existing literature at this point. What will be new to the literature is what we're finding here, and that I'm quite excited by this finding. So we looked at brain glutathione levels in the two areas of the brain that are highest risk for developing brain lesions. And we saw a significant increase by 12 months in glutathione levels in both brain regions. So we think this is good. I think this is promising. Again, I can't make a causal claim here because we don't have a significant association with vitamin D level, but we think, again, this is in keeping with some of the larger literature here. We're quite excited about this. Lastly here, this I think is a pretty neat finding that became a bit of a post hoc analysis that I was thinking about halfway through the study, and I was excited to get collaborators at Stanford, Greg Zaharchuk and Moss Zhao, to help us analyze this. But this is basically cerebral blood flow as measured by this MRI technique called arterial spin labeling. And this measure, so the bright red here means more blood flow, blue means less blood flow. And if you recall from earlier, as I was showing you with stroke, the problem is you have too little blood flow, and one of the that may be a risk factor for cerebral lesions to form. And one of the neat things here is that when we look at the whole brain, we see an increase in cerebral blood flow in the areas that we are generally highest risk. In fact, the areas we were measuring in the spectroscopy for cerebral lesions. So we see an increase here. You can see this qualitatively in this measure here in the occipital region, and then the frontal region is very much more subtly. We had set out to look just at the blood flow in the full brain, in the splenium, and this is looking at the relationship between cerebral blood flow and vitamin D levels. We're using their baseline levels. We don't see a significant association here. At month 6, it looks maybe a little more convincing. And then at month 12, it seems to maybe whether this is the vitamin D level kind of yoking cerebral blood flow to its exposure or not. We did get a significant association here. I don't believe this is corrected for multiple comparisons, but it does look like, I think this is a really intriguing and promising area here. We have a kind of a long backstory for what we think the mechanism is here. I'll have to detail at some later time with some additional studies, but we think this is actually a really exciting and promising area in addition to the antioxidant measures that could be quite promising for at least a potential mechanism for whether, if vitamin D might have a mechanism in preventing cerebral lesions, this might be a clue to part of it. So up next, what do we have in mind? Well, we've got, I think Stefan Kemp is going to be working with us. We've got yet to formalize some of the things, but with some of the lipidomic profiling, we're working with the Snyder Lab and the He Lab, both at Stanford, on some multi-omic sequencing and profiling. And Do-Hyuk Kim is a really wonderful postdoc in our lab who's going to be leading the computational biology effort here. I want to make sure people know that this additional work is not funded by the NIH, as was the rest of the grant. This is actually funded by philanthropic gifts from the Lanai-Yoler family, the Adler family, and the Broussard family. These are really expensive assays. Some of these last 2 assays are going to cost our lab a couple $100,000 to run on just our 30 or so samples that we're doing. And the Maternal Child Health Research Institute at Stanford is also funding some of this work and some of the salaries here. So in summary, we have a pilot study that achieved target vitamin D levels at 40 to 80 nanograms per mil for most patients. We had weight-based dosing that was associated with fewer adverse events. We had an association between vitamin D, glutathione, and brain perfusion that just warrants further investigation. And we're planning to proceed to a phase 2 trial with age and weight-based dosing regimen and some exciting metrics as well. We're moving into some mouse work, and we'll be doing some multi-omic profiling. So I think I've only got about 2 minutes here to spare, if that, before we go to our next talk. So I may not have too much time for questions. I do want to encourage you to get to the next talk on time, and maybe we can field some of these questions at a later time. But want to thank you for joining here, and we will move on to the next talk.